I'm Ann Spolarich. Greetings from Phoenix, Arizona. I am professor and the assistant dean for research at the Arizona School of Dentistry and Oral Health. We're part of A.T. Still University. We are an osteopathic university. I teach pharmacology and clinical medicine, and I'm faculty in our residency program, as well as faculty in our advanced care clinic, where I treat patients who are highly medically complex, and my research revolves around best practices for caring for people with a whole host of special healthcare needs and medical complexity and in cancer biomarkers. So I'm so delighted to be here today because I get to talk about things that I encounter absolutely every day that I am with my own patients. And I look forward to hearing from all of you. So I'm going to go ahead and pull up my slides. I think everybody can see that now. So we're going to talk about adverse events related to medication use. And I have quite a bit of material and ground I want to cover today, and I've embedded some cases to illustrate what we're talking about. I think it's always nice to be able to see pictures of the conditions that we're discussing. And before we kind of dive into all the specific oral side effects that we see with medication use, I want to sort of set the stage to talk about polypharmacy and how drug side effects are really related to polypharmacy and oral side effects. This is something that I certainly encounter and manage all the time with people with medical complexity, as do all of you. And we'll talk also about the role of saliva in how it maintains oral homeostasis and what goes wrong when medications have an effect on saliva. And we know that chronic dry mouth is a really common oral complication observed by patients of all ages, by the way. I know we think about this with older adults, but we have children who are taking medications that affect salivation. So we'll talk about what is the role of chronic dry mouth on comfort and ability to function. And then we'll go through a whole set of common oral complications and some of the medications that are associated with causing them. So, when we take a look at medical complexity, we also refer to this as multimorbidity. And you're really talking here about when people have two or more co-occurring chronic health conditions. And certainly when we look at the US population, we know that this is most of the adults that we see in our practice settings. This is especially common, of course, in older adults, and treatment and management is much more complicated because we have a lot of providers who are contributing to the mix. We know when people have multimorbidity and polypharmacy, they are much more likely to experience a negative effect on a variety of health outcomes, including decreases in quality of life and a decrease in the way people self-rate their own health and decreases in mobility and functional ability. We also see increased risk for not only side effects and also the more serious toxicity reactions, but also hospitalizations, more issues with both physiologic and psychological distress. And we know that, of course, those individuals who are affected are going to have much higher healthcare costs because of their increased use of healthcare resources and ultimately higher risks for mortality. So, who do we see with polypharmacy? Listed here are just some of the more common populations that I deal with in my own clinical facility, but I think we can certainly see how these conditions align a lot with chronic diseases of aging and certainly representative of the most common types of conditions that affect the US adult population. So there's going to be other people, right, who don't make the list. But these are, I think, some of the biggest patient populations that we care for in practice who will definitely be challenged with managing all of their medications. And it creates an opportunity for all of us to collaborate between our respective disciplines so that we can practice and care for these patients more safely as we're caring for our mutual patients. So, as a background introduction to our talk today, we know that there are actually thousands of medications on the US market that are associated with oral side effects. But when we think about oral side effects in the grand scheme of side effects, they're actually considered to be fairly rare. And that's sort of defined in the pharmacology community as those kinds of oral complications that affect less than 5% of users. And the overall big exception to this rule is, of course, dry mouth. And we know there are many classes of medications that are used to control chronic diseases of aging that are associated with causing chronic dry mouth. And you see, I have a bunch of them listed here. It is by no means a comprehensive list. I'll show you a bigger list in a few minutes. But here we're talking about things like antihistamines, antidepressants, or anti-anxiety meds. Pretty much all neuropsych meds are associated with this problem, and it's first dose related. So if people are taking antidepressants and anti-anxiety meds together, which is very common in the adult population, you are certainly going to see chronic dry mouth. Antihypertensives, another major category, and multiple classes of cardiac meds cause dry mouth, and by multiple different mechanisms. Sometimes it's simply a function of volume loss related to a diuretic type action. You have sedatives and sleeping pills, of course, all the over-the-counter allergy and cold medications. And then I put here, as we all know, people with dementia take medications that have a lot of different side effects, and sometimes they're put on anticholinergic drugs to offset other kinds of side effects that the patients are experiencing. And so we can see certainly chronic dry mouth in that population. It tends to be very profound. And what I want you to take away from this is that medications can actually cause dry mouth by a couple of different specific mechanisms. They can alter the production of saliva, they can alter flow rate into the mouth, and they can also alter the chemical composition of the mouth, the saliva in the mouth. It might surprise you to know that you actually have to lose half of your salivary flow before you're symptomatic. So a lot of people have, quote, dry mouth without really being symptomatic because they're experiencing more of the chemical composition prior to actually becoming symptomatic. So we know normal saliva is regulated by the autonomic nervous system. And so depending upon which division of the autonomic nervous system is affected, kind of drives how the person will experience their dry mouth. So the parasympathetic nervous system, of course, we think about with your rest and digest mode. And so you need saliva. Saliva carries all the essential enzymes that are really part of the first stage of digestion. So saliva is necessary to break down foods. And so the parasympathetic nervous system drives the high volume, high ion containing portion of the saliva. And the fluid component of the saliva comes from your parotid glands laterally. And patients who have drugs that affect the parasympathetic nervous system, we can either use drugs to turn on this particular type of flow where we could increase volume, or most commonly, people are on anticholinergic medications, which reduce parasympathetic stimulation. And so that's the patient who has more of a volume loss. So those are your patients who are going to complain about feeling parched with their dry mouth. Versus when we look at the sympathetic nervous system, this is what primarily controls the mucinous saliva that's secreted from your submandibular and sublingual glands. It's very high in protein but lower in volume. So this is the portion of the saliva that has that sort of viscosity when we think about saliva. And so when people take medications that mimic the sympathetic nervous system, they tend to have more of a stickier type of saliva. And so you'll have patients who will complain of having stringy or ropey saliva. I see this a lot in my patients who are going through chemotherapy, where the flow that's coming from the submandibular and sublingual glands tends to be more predominant, and they complain about feeling sticky and goopy. And actually, patients tell you they have to spit a lot because they just need to clear that mucinous saliva that's there. When we think about the components of saliva and what do they do, saliva does many, many things for us. I think most of us think about saliva from its lubrication type of effect, because that's the one that affects us the most. So when we have a loss of the mucins that are the protectants, that are the lubricants that are in the mouth, that compromises tissue integrity. And so people will have problems with trauma. They'll complain that their tongue and their cheeks are sticking to their teeth. The tissue gets very friable. It's easy to tear. It will even stick to your finger, a gloved finger, when you go to examine the patient. It will also allow for more trauma with eating. Normally the epithelium that lines the oral cavity turns over quite quickly. So, you scratch yourself accidentally eating a tortilla chip or something sharp, it turns over and repairs usually in a day or two. But in patients who have lost this natural lubrication and protection property, you'll see more trauma and more ulcerations and lesions in their mouth. We know that saliva contains a lot of natural immunoglobulins that are essential for fighting off disease, but also for maintaining a symbiotic type of ecosystem. So we have a nice balance between healthy flora and the pH of the oral cavity and a defense against keeping opportunistic bugs quiet and down so that people don't end up getting more infections. So when people have a drug-induced dry mouth, you're going to see more periodontal disease. You're going to see more dental caries. These are, of course, bacterial in nature, but you'll see more fungal infections. Candidiasis, of course, very common in people with dry mouth, but you'll also see more viral breakouts. So people who have herpes virus will be more likely to get lip lesions. Be more likely to have intraoral herpes as well. Saliva also contains sodium bicarbonate and phosphate, which are important buffers. And so if you don't have enough saliva or the chemistry has changed, that loss of buffer means that the pH really drops. So you'll see a more acidic environment, and that is an essential contributing factor to demineralization of the tooth structure. It first manifests with what we call white spot lesions, which are then highly susceptible to decay. We also know that the biofilm that naturally exists in the oral cavity also tends to become more acidic. And so some patients will complain of tooth sensitivity as it's sitting on top of the teeth, especially if it's on exposed roots. And you'll also find that patients, when they get decay, it tends to progress very quickly. And I'll show you some examples of that. We also know that the electrolytes, the calcium and the phosphorus that are in saliva are really essential to maintain the good mineral content of the teeth. So we think about it for structural integrity of the teeth. And the proteins I mentioned are there to play a role in digestion. And it might surprise you to know that many of your patients who are coming in and they're telling you they're having problems with reflux and they're getting evaluated, many of those people have dry mouth. And a lot of us are not making the connection because people are not able to break down their food correctly. It gets stuck. They're trying to swallow food that's too large, hasn't been broken down. So keep that in mind when you're evaluating your patients. And then the natural fluid component of saliva is essential for cleansing the oral cavity. So if you've worked in a nursing home setting, I see this a lot there with older adults who are coming in to see me, who are not getting routine oral care. We see a lot of neglect, and we see a lot of food pouching in those patients. Their food is getting stuck up in the vestibules behind the teeth, and it's because you've lost that ability of the saliva to naturally push the food down towards the occlusal surfaces of the teeth during the chewing motion, and it causes infection and bad breath. You also need saliva to carry tastins over your taste buds. So lots of older adults complain the food doesn't taste good. It's too bland. I have to use a lot of salt. I have to use a lot of seasoning. And part of the problem is they don't have the saliva that they need to carry the tastins over their taste buds. So you see, there's a lot of things that can go wrong when saliva is reduced. So this is just a nice review for you to think about all of the types of risks and complications that we see with dry mouth. And you'll notice I've been saying dry mouth because dry mouth really refers to loss of volume. Xerostomia is the perception of a dry mouth. And people can perceive that their mouth is dry without actually having any change in their flow rate. And of course, they can see it directly related to the amount of volume of saliva that they have. Sometimes inhaled medications that do nothing to change flow rate often will give people the sensation that they feel dry. So think of the term xerostomia as the subjective versus dry mouth, which is more objective because it relates to flow rate. So a few of these things we've talked about, but just another thing to mention is loss of lubrication makes it also difficult to wear dentures and oral appliances. It also makes it difficult for people to function. People will often have problems with speaking and with swallowing. And then, in addition to the digestive problems that we mentioned with decreased flow, you'll see more oral discomfort, friable mucosa. Sometimes the tongue will appear atrophied and more infections, and of course, difficulty with cleansability, swallowing, things like that. All of these things add up to a reduced oral health related quality of life. So I mentioned earlier that you have lots of natural immunoglobulins in saliva, and when you have chronic dry mouth, we see a lot of opportunistic infections. And this is a really classic picture of somebody with a drug-induced fungal infection. But just to let you know, there's lots and lots of medications that also predispose people for getting oral fungal infections. And this is really in addition to talking about outside of just the medical conditions themselves that also predispose people to fungal infections. And so we know when people are immunocompromised, for example, this is a really common time that we're going to see people with fungal infections. So the kind of the worst offenders would be inhaled steroids for asthma and COPD, uh, oral steroids that are used for autoimmune diseases, but are also used in supplementation for things like in our patients post-organ transplant, and sometimes used in cancer treatments. All of the newer immunosuppressants fall into this role. We have a lot of patients on immune modulatory drugs, and then, of course, immunosuppressants used for cancer therapy. Antibiotics and hormones can do this, as can the proton pump inhibitors for reflux disease. What's interesting about the PPIs is that the candidiasis tends to appear lower in the esophagus. And by the time people notice it and it comes into the oral cavity, it's a much more fulminating type of fungal infection. And we have to often hit that harder with oral antifungal medications and treat it systemically, as opposed to just a topical treatment. But fungal infections don't always have that cottage cheesy type of appearance. They can appear in a lot of different ways. You can have a pseudomembranous appearance. You can have an atrophic tongue. You can have a hyperkeratotic appearance. You can see this a lot in denture wearers. Somebody's geographic tongue, which is by itself a normal condition. It's just an atypical organization of the papilla on the tongue. But in people who have a symptomatic geographic tongue, often reflective of a fungal infection. And angular cheilitis, which you see in the lower left, which we typically think about associated with a vitamin deficiency. In actuality, about 95% of cases of angular cheilitis are fungal in nature. And what we see is, especially in older people where they've lost teeth, you have a loss of vertical dimension. And so that upper lip tends to overlie the lower lip. And those fungal organisms that are floating around in the saliva end up pooling in the corner of the mouth. You'll also see this in people sometimes unilaterally post-stroke. So if you're evaluating your patients, I would really recommend that you certainly rule out vitamin deficiency, but remember that the majority of these cases are fungal in nature and that you consider treating it with a topical antifungal. So just as kind of a review, we had said that the parasympathetic nervous system typically is responsible for increasing the fluid volume or the serous portion of the saliva, and we would refer to that as a cholinergic effect. So sometimes we do this to our advantage with medications where we give them to people to turn on and increase their flow. And we have two drugs that are approved for use in the United States for this, pilocarpine and cevimeline. They are FDA approved for patients with Sjogren's syndrome and people who have gone through radiation therapy to the head and neck region for head and neck cancers where the saliva glands have been affected. Not everybody can use these drugs. You have to be careful because they're used systemically, and so they're going to turn on all exocrine glands. They have increase your tear production, secretions in your nose, you sweat a lot, and there are some contraindications too. Medically. So not everyone is a candidate for those medications. So you definitely have to check for compatibility before they're prescribed. But by and large, medications that are used by patients are typically anticholinergics. And some of these I showed you earlier. Here's where your antihypertensives and antihistamines, your antidepressants fall in. Some other more common drug families that fall into this category are the antiemetics, antispasmodics, your muscle relaxants, drugs for Parkinson's disease, and many of the drugs that we use for dementia. And so you're going to see additive dry mouth effects with those. With the sympathetic nervous system, so we said really is responsible for that more mucinous or sticky kind of saliva that's more viscous. And so drugs that act like the sympathetic nervous system would be things like decongestants, bronchodilators, appetite suppressants, and amphetamines. And we typically in this country are prescribing amphetamines for ADHD. But remember too, people use illicit stimulants as well. So you will also see this manifestation, for example, in people who are using street drugs like methamphetamine. So here's just a little summary for you. If you have your phone, you're welcome to take a picture of that. And these are just kind of the more common families of drugs that we associate with chronic dry mouth. Now, I also just want to quickly mention to you, you'll see that I have opioid analgesics there. When we're using opioid analgesics for acute pain, and of course, we're all very much aware that we're really reducing our use of opioids for acute pain control, certainly in dentistry and in medicine together. But we do have some patients who are using opioid analgesics long term. So you have some patients who have, for example, later stages of cancer. Maybe they have tumors that have metastasized to the bone, very painful conditions where they're going to be using opioids. I had a patient just last week who had a really severe injury to her vertebra. So she is on morphine long term, right? You also remember we'll have some patients using drugs like Suboxone, which is an opioid, but it's used in low dose form as part of substance use disorder treatment. So you will have patients who are on opioids chronically, and it is associated with dry mouth. So I just want to kind of highlight that and call it out to you because we don't typically think of those as drugs that are used chronically. Here's an example of a patient who's undergoing head and neck radiation, and you'll see we try to illustrate here where the field of radiation is. And of course, we try very, very hard to spare the glands whenever we possibly can in the field. It's not always possible to do that. And we also try to use blocking agents in when we set up the patient to receive their treatment, many of you know that as like a lead stent, so that we try to spare exposure to the contralateral side. And newer forms of radiation therapy are much more targeted, and that's a good thing because we find that we can really save a lot of the salivary gland tissue on the contralateral side. We know salivary glands are very sensitive to radiation, especially the acinar cells that are in the parotid glands. And so in your patients who've gone through head and neck radiation, the parotids tend to really become more damaged. And that means that you're going to see those patients have the big volume loss and really complain of being more parched. They're really noticing the volume loss. The other thing to remember is that we have ways, like I said now, with more targeted types of radiation therapy to try to spare those glands. And you will get some recovery with radiation over time as some of those glandular cells turn over. Nobody's going to come back to where they were at baseline, but after about 6 months, patients often will start to perceive that they're getting a little bit of recovery. This is a patient of mine I wanted to show you. And So for our medical colleagues who are joining us today, one of the things we recommend is that patients use very intensive fluoride therapy for life after head and neck radiation because the chemistry of the saliva is different, much more acidic. We also know, right, that they're going to have a big volume loss, they're going to lose their buffer, all of those kinds of things. And so people really need to have exceptional oral hygiene and they have to be very compliant with at-home high potency fluoride use for the rest of their lives. And if you take a look at these pictures, what you see is very healthy pink tissue. Um, the hygiene is pretty good. This was a patient who came to see us. We examine all of the head and neck patients here locally to clear them for dental treatment. And this was a really nice lady. And what happened was 3 months later, after radiation, she was very, very poor with her compliance with using her fluoride, and she presented with 64 new carious lesions. And if you take a look, you see they're all right around the gum line. And we actually call this phenomenon radiation caries. It is very rapidly progressing. And the problem is that it goes up around the gum line and on exposed root surfaces because there's no enamel. So the underlying tooth structure is the cementum on the root and dentinal exposure, and it's much easier for the caries to plow through those surfaces. And this is a terrible situation when this happens because it's a lot of restorative work, and then it becomes harder to clean around all the restorations that are around the gum line. So it is a self-fulfilling prophecy. So we really need everybody on the team who's caring for those head and neck cancer patients to really be promoting compliance with fluoride use. We never want to see anybody deteriorate as quickly. So,
And
okay, go ahead.
there's a question in the chat. I'm not sure if you
Okay,
saw
let me
that.
see.
Do
Okay.
you want to say that for later, or do you want to answer it now? It says
Oh,
the is the methamphetamine associated dental loss due to sympathetic effects?
so that is a great question. So, methamphetamine associated tooth loss is actually caused by a whole host of factors. One is because we know self-care really goes away. So we see all kinds of personal hygiene become reduced, and that includes oral hygiene. Also, methamphetamine produces a central effect where you crave carbohydrates and sweet things. And so many people will eat a lot of sugary foods and then they crave things like soda. And so the colas that are sugar based. So remember, bacteria in the mouth consume the sugars and carbohydrates as their fuel. And the byproduct of that metabolism of those sugars is acid. And so you have this then exposure to acid, which is weakening the tooth structure and the teeth decay very quickly. So as long as the person's eating a lot and drinking a lot of carbohydrates while they're under the influence and not doing hygiene to remove the plaque biofilm, the bacteria, it's like a vicious cycle. The other thing is, depending upon how the person is making methamphetamine, it can be synthesized a couple of different ways. Um, One of the ways people do it is to use highly acidic types of sources. People, for example, use fertilizers. They can use batteries. They can use all kinds of things. And that is another source of acid in and of itself. So it's lots of different things. They also, any drug like that that has stimulant effects really turns on clenching and grinding. And so people are wearing down the teeth. So puts a lot of stress on the teeth that contributes then to the periodontal problem and the bone loss around those teeth. So tooth loss from caries, from periodontal disease, neglect, etc. I hope that was a good answer to your question.
Thank you.
Sure. Okay. So watching our time, this is another, I apologize. Some of these pictures are a little bit tough. One of the oral complications associated with radiation therapy is a condition called osteoradionecrosis. And this is an area where you get exposed bone that has been irradiated and it's no longer vital. And so what happens is we have a failure to heal. And it typically shows up about 3 to 6 months in the absence of cancer, so post-treatment. We know the risk is higher in the mandible because blood flow in the mandible is is really contained inside of the mandible that's surrounded by bone, so it's harder to deliver nutrients to turn over and repair bone versus on the maxilla where we have much more vascularity. Typically, if it shows up early after treatment, it's more associated with very high doses of radiation in a short period of time. The majority of cases of ORN show up later, like we say, months after radiation is complete. Risk factors are things like getting more than 60 grays of radiation. And I can just tell you, since this is my population I work with, almost all head and neck cancers are treated with very, very high doses of radiation. They typically average between 60 to 70 grays compared to other types of cancer. So this is a big risk factor for us. Trauma is another contributing factor. So we don't like to extract teeth in bone that's been irradiated because the bone doesn't heal. So trauma from a surgical procedure. Also, if the tumor was close to the bone or had invaded into the bone, so the residual bone has changed in its quality and quantity, and then having poor oral health and poor oral hygiene as a risk factor. This is really sad. It requires surgical intervention and resection. Okay, sorry, my slides have frozen here. Hold on. Okay, let's see. Let me do it this way. Okay, so closely tied to chemotherapy, another treatment for radiation, and many head and neck cancers, especially those that are treated that are HPV positive cancers, are treated with both radiation and chemotherapy. But we know chemotherapy is used for all types of cancers, and it is notoriously linked to mucositis. We know chemotherapy can also damage salivary glands, and we know that it alters flow rate as well as composition of the saliva. The extent of the damage really varies with the type of agent and duration of treatment. And then you have the secondary risk of systemic immunosuppression, which alters the concentration of those natural salivary immunoglobulins that we talked about earlier. And the net effect is this very painful condition of mucositis, as well as risk for oral infections. And we also know that to make things worse, lots of chemo drugs cause dry mouth, and the severity is based on the number of agents used. And most common cancers, head and neck cancers, lung, breast, prostate, are all treated with typically dual chemotherapy, and it's because the agents work at different parts of the cell cycle, and so you can get a better effect if you use more than one drug. But then you have greater complications also throughout the body in addition to the oral cavity. We don't really understand the mechanism of action in terms of what is happening within the gland itself, but we do know that mucositis is closely tied to the fact that the drugs are secreted into the remaining saliva, and they'll actually appear more concentrated because you don't have as much volume. And then you have exposure of those agents directly in contact with the oral tissues, causing this toxicity reaction. Oral ulcerations can also occur from medications. Mucositis is certainly the worst example of that. Or other oral ulcerations can be smaller lesions that can be individual, or they can be larger and they can coalesce. We know they are painful, and that affects function, eating, speaking, swallowing. Also, people have a really difficult time sleeping when they experience ulcerations. Now, lesions like the one you see here, which is a typical aphthous lesion, it has that very classic sort of gray membrane in the center. It's a little cratered out, followed by that red halo of inflammation. These aphthous lesions typically run their course. If they become larger or more severe, we can use things like topical steroids to treat them. But many times we just use topical anesthetic agents. Some of them are over the counter. They're benzocaine-based products just to keep people comfortable. But if people are getting recurrent ulcerations, and we know that some drugs really promote recurring ulcerations, then we may have to work with the prescriber to either temporarily or permanently discontinue that drug. So it really depends on the patient. And if I have patients who it's just really tough for them to function, we do a consultation with the prescribing physician, and we say, is there anything else that maybe could be substituted? But some common drug families here would be your NSAIDs, beta blockers, and ACE inhibitors. And these are among the most commonly prescribed medications in the United States. ACE inhibitors, lisinopril, is one of the number one drugs prescribed in this country, anticonvulsants and antidepressants. The recommendation is that for any ulcer that doesn't go away on its own within 2 weeks, the patient should be brought back in for follow-up care and evaluation and biopsy potentially, right? Kind of coming down to the end of our list here, I thought it would be helpful to mention that there are a lot of drugs that actually turn on clenching and grinding and other types of movement disorders. And the worst offenders are the antidepressants that affect serotonin. So those would be your selective serotonin reuptake inhibitors and your selective serotonin norepinephrine reuptake inhibitors, some of those newer antidepressants on the market. But stimulants, including illicit stimulants like cocaine, methamphetamine, and ecstasy, also turn on clenching and grinding. And you'll see this wear in these photographs, right? As the occlusal surface wears down and becomes very flat, the incisal edges become chipped and sharp. And so people can cut their tongue and cut their tissues on that. And also remember, we can't get that tooth structure back. So if there's a way we can, if it's from antidepressants, and we see this often in dentistry as, hey, wait a minute, you've been my patient for a long time, and all of a sudden now I'm seeing signs of this. I always like to remind everybody, we'll check to see, is there a new medication that's been put on board since the last time? And I remember when the first case reports came out in the literature, it was just with Paxil. And we're all going, I'm a physiologist, right? So I'm going, like, what's the mechanism? What's the mechanism? And it actually turns on a portion of your spinal column that controls involuntary movement. And so you see this clenching and grinding as a manifestation of that. And now we know it isn't just Paxil, it's all these drugs that affect serotonin. But we're seeing a lot of use now of antipsychotics. Typically, we thought about them only in the context of schizophrenia, but many of the new, what we call atypical antipsychotics, are used for bipolar disorder. That's one of their most prevalent types of indications. I would say you see more prescriptions for bipolar, but sometimes they're also used in patients with dementia. There's a lot of controversy over whether or not they're a good fit for people with dementia for lots of different reasons. But you will also see things like tardive dyskinesia associated with antipsychotic medications. And it almost looks like grimacing, lip smacking, mimics chewing, things like that. And we have medications now that can be prescribed to offset that. I mentioned earlier that having chronic dry mouth is problematic for taste, but there's actually over 350 drugs that alter taste and smell, and that includes more than half of the top 100 most commonly prescribed drugs in this country. The most common complaint of taste alteration is a metallic aftertaste, like it feels like you left a little bit of the tinfoil from a piece of chewing gum wrapper in your mouth. Other people will complain of a reduced taste sensation, and it can vary, right, with the type of taste, sweet, salty, sour, or bitter. Antibiotics, antihypertensives, medications for GERD, and metformin, right, number one intervention for type 2 diabetes. These are some of the worst offenders for altering taste. And I did mention that you need saliva to carry tastins over your taste buds. So you will see taste alteration again in anybody with medication related dry mouth, sorry. Just as a little sidebar, I'll tell you, you have to be careful because people hate taste alteration. And they will do lots of things to try to offset this. They can be excessive mouthwash users that can cause issues. They tend to be people who are carrying, mints, gum, candy, like they're always sucking on something to try to offset that. And so in dentistry, we get caught sort of in the back door of that, where all of a sudden we're seeing this patient and we're seeing new demineralization, white spot lesions, early caries. And it's because of the habits that the person has adopted to try to offset the aftertaste. And there's many mechanisms to explain why this happens. Sometimes people have different conditions where it changes the rate of turnover, the natural turnover of taste buds. You'll also see sometimes that you will have drugs that actually will be secreted into the saliva, and that's what's causing the taste. Lots of different mechanisms, a little beyond what I wanted to get into today, but just be aware that this is a lot more common than you realize it is. Here's enlargement of the gum tissue. This is a condition called gingival hyperplasia. For our periodontists who are here attending, you are very familiar with this. Worst offenders are some, not all, of the calcium channel blockers, anticonvulsants, and immunosuppressants. In these individuals, you have an upregulation of fibroblasts and they produce excessive collagen. So the tissue appears to be swollen, but it's actually firm in nature. You do have the gene for this. So every one of us is what we call either a responder or a non-responder. And many years ago, I was involved in some of the early studies with nifedipine and cyclosporin, looking at this manifestation in our patients. It is a benign condition, although it can be severe enough where it will overgrow the occlusal and incisive edges of the teeth, and then people are biting on their tissue. We have to surgically resect it. But I want to point out how important it is to know that if you have the gene and you're taking the drug, you will respond in this way. And it won't stop until you discontinue the drug. But what we do know is that good oral hygiene, while it won't prevent the overgrowth, it will help to limit the severity for as long as the patient remains on the drug. And this is important to know because sometimes if patients get this from an anticonvulsant, it's not so simple to switch them to a different one, because if that's the best choice that controls the frequency and severity of the seizures, we have to keep the patient on that anticonvulsant. So what are we going to do in the meantime? And I brought a picture of this. This is one of my patients who's on nifedipine. And what I want you to see is, and notice that the tissue is very pink and the hygiene is really good. But where do you see this bulbous tissue? You see it in areas where there's malpose teeth that are harder to clean, right? So you see more of this manifestation where the person has to really consciously try to adapt their toothbrush and get in there and keep it clean. And this is somebody who I ended up putting on an oral irrigator and an antiseptic mouth rinse, and the patient did really well. So we just have to remember that we have the tools and the products that can help with this, but oral hygiene is so critical for limiting extent and severity. These are some more, I think, severe manifestations of this. The picture in the upper left, a colleague of mine sent to me from another part of the country. I can just say personally, I have never had a patient on a calcium channel blocker with that severe of a manifestation. If you see that, that's going to be somebody who likely is not having any kind of regular access to dental care. You'll see you might notice in the upper picture here, I don't know if you can see my cursor, there's an abscess tooth here, poor oral hygiene. And then you get a secondary inflammation over top of this. Here's cyclosporin, a similar type of manifestation, and again, phenytoin, right, dilantin, which we see in kids a lot with gingival overgrowth. So again, you can actually see how this is approximating coming down closer to the occlusal surface in that lower right picture. And we do have to do a surgical resection for those kinds of cases. And then last but not least, I wanted to mention probably one of our most severe types of oral complications, which is what we call MRONJ, medication-related osteonecrosis of the jaws. And this is a notorious but relatively rare type of condition that's quite serious. People get open lesions in the mouth and that expose the underlying bone and it fails to heal. Not everyone is symptomatic, especially in early stages, but some of these lesions can become quite painful, excuse me, and it does require professional intervention. various organizations professionally have new criteria to stage the severity of the lesion with corresponding treatment protocols. But what are the drugs that are sort of the worst offenders for this? Think about your anti-resorptive medications that are used for osteoporosis. So these would be your bisphosphonates and your rank L inhibitors. Also, some drugs that are used as part of cancer treatments. So this would be your anti-angiogenics. You will have your mTOR inhibitors, your tyrosine kinase inhibitors, for example, and even high-dose steroids that are used as part of cancer treatment are associated with this. Now, the effect is also dose-related. So when you think about bisphosphonates, the risk is actually about 1 to 2% with oral medications. When those drugs are used as part of cancer treatment, you're talking about using a dose that's 4 times higher than what's used for osteoporosis prevention and treatment. And so it's a dose-dependent effect. And there you're talking at like a minimum of around 20% of users of high doses of bisphosphonates will get this. So um, and these are drugs, you can get this with drugs that are administered orally or by infusion therapy, but this is much more common to see in your patients who are using a whole host of these medications as part of cancer treatment. And I think many times in dentistry, we forget that bisphosphonates are used for a lot in stage 4 cancers because many common cancers like breast cancer and prostate cancer metastasize to the bone. And they've shown wonderful benefits at reducing size of the tumors and increasing length of disease-free survival. So they're always going to be a good choice and a part of management for stage 4 cancer. And we just have to be aware and examine those patients regularly, encourage people to have really good oral hygiene. We know risks for this are higher in people who have a smoking history because, of course, smoking has significant detrimental effects on bone quantity and quality. Steroids, people with poorly controlled diabetes, as I mentioned, people going through chemotherapy, poor bone quality. So I always recommend consulting with an oral surgeon for evaluation and treatment in cases of MRONJ. And I just brought some pictures to show you. Excuse me, we know they're not very pleasant to look at. Can really be a devastating condition for patients. Have had many patients who've had this who have gone through high dose chemotherapy. So today we've talked about chronic dry mouth, most common oral complication, and all of the side effects that are negative that impact comfort and function and quality of life. And remember, sometimes we have to think about discontinuing a drug if the oral side effects are really severe. Like we worry a lot when people can't eat, people can't sleep, then we have to do maybe something that's a much greater intervention for that patient. And that means collaborative care is going to be really essential for proper patient management. So I want to thank everybody who is a part of this wonderful program. I'm so honored to have been a part of it. I'm going to stop sharing my screen and see if there's any questions for me.
I don't see anything in the chat, but does anyone have questions? Feel free to unmute or put those in the chat.
Yeah. I have a question. Sorry, this is Jamie. I can't get my camera working, so I'm sorry about that. But I'm wondering if you have any suggestions for xerostomach over-the-counter medications that you prefer for patients that are helpful if they suffer with that.
Yeah, this is a great question. And you know what? You're not going to like the answer. The answer is that there is no one size fits all product. And that's because remember, everybody's dry mouth feels different, right? So some products are designed to have more of the natural viscosity of saliva. And a person who has the sticky saliva doesn't like to use those because it feels too sticky. It actually makes their sensation worse. So I find that people need to try a lot of different things. There are good products that are lozenges. You have some like a quick dissolve lozenges, some that actually adhere, you can adhere them to the attached tissue in the mouth for a slow release overnight. One product that I really love that is water-based that is actually great for your mouth breathers, people on CPAPs. lot of problems with dry mouth in that population. It's the Biotin Oral Balance Gel. And it's water-based. And it can be, you can put it on your finger and smear it around in the oral cavity. It's safe to swallow. So I find for nighttime relief, that's very helpful for a lot of patients. It also comes kind of as droplets and sprays. There's a whole list of products that are out there. I don't know if you want me to be promoting them or talking about them. It's just sort of my my opinion and my experience with them. But I think you have to do a lot of trial and error with patients. And listen, the most important thing you ask your patient, they'll say, "I use product X," and I'll say, "Well, is it working for you?" And inevitably they say no. I'm like, why do you keep using it? Like, let's try something else that might, in fact, work for you. So there's a lot of stuff that's on the market, a lot of things that are available.
Thank you. That was wonderful. I
Great.
actually have one more question. I don't want to monopolize the session, but how about xylitol containing products?
Yeah, xylitol is really good for a lot of reasons. Xylitol is really helpful for reducing strep mutans and lactobacillus that are associated with caries. So you'll find many dry mouth products actually have xylitol in them, and I think it's a good thing. If your patient has teeth and they are comfortable chewing gum, xylitol gum can actually be really nice. There's a lot of products that are designed for people with diabetes that are sweetened with the sugar alcohol. Xylitol is one of them. So candies and things like that. There's lozenges. There's all kinds of xylitol-based products. There's also sprays. I use them a lot. It's great. But the thing you have to watch is it's pretty hard to reach the toxic dose. But people who are consuming too much of that in one day will get diarrhea because you can't metabolize and break down the sugar alcohols. And that's a side effect of it. So I always, like when I recommend a xylitol to patients, I just kind of mention that to a side as kind of watch for that. And I love the true story that I tell everybody. A chiropractic office I went to for a long time used to have a basket of candy on the desk where you checked in. And I said, "You're health professionals. You should not be doing this. That's not okay." And so to appease me, they switched and put sugar-free candies in the basket. And I came in for an appointment and I'm looking, all the people at the front desk were kind of green around the gills. You know what I'm talking about? And I kind of went like this and I said to the receptionist, I go, "Y'all have diarrhea, don't you?" She goes, "How can you possibly know that?" I said, "Because you were picking out of this basket all day long." And now he gives out keychains, and that's a true story. So there you go. So they're great, but you do have to be aware they have side effects too.